Imagine that the reason why I'm invited here as a health economist is to give the outsider's view on many of the topics that you've been talking about. So I will try to do that. And the title I was given was the socioeconomic kind of impacts of severe congenital heart disease. And I took the liberty to actually change the title quite a bit to talk even more broadly around the economics, outcomes, and policies surrounding congenital heart disease. So here's what I'm going to be talking about in the next 20 minutes. I will talk about the economic burden of congenital heart disease and the shifting nature of this economic burden with the aging congenital heart disease population. And then I will highlight the need to scrutinize service delivery around the types of interventions that are delivered to patients, the types of organizational and workforce-related issues that we may need to revisit with the changing nature of the population, and also the costs associated with congenital heart diseases. And I will try to advocate or push for the role of outcomes research as potentially a new framework to generate much needed evidence on the comparative clinical effectiveness as well as the comparative cost effectiveness of different types of interventions, strategies, and programs that may be relevant to inform future policies. Of course, as a health economist, it's not my place to reiterate that congenital heart disease is complex. But what interests me as a health economist and also health policymakers is that it's a costly condition. It's associated with lifelong comorbidity that impacts health services utilization and costs. And although it's a relatively rare condition, what policymakers like to point out is that it consumes a disproportionately large share of available healthcare resources. In the United States, for example, hospital costs alone for children with congenital heart diseases is around $1.8 billion, which of course is a huge underestimate of the total economic burden of this condition. If you take into account the productivity losses of the parents taking care of their children or the psychosocial burden associated with congenital heart diseases, this figure would be a huge underestimate. And beyond childhood, significant costs are associated with the types of resource utilization that's required during adolescence, adulthood years, and also in geriatric types of populations. So as an outsider, congenital heart disease seems to be costly because it leads to numerous hospitalizations, and it tends to require services of a multidisciplinary team of specialists. And it requires the use of both advanced, innovative, and also often expensive types of technologies. If we were to look at the hospitalization rate associated with different types of congenital heart diseases, here we're looking at severe congenital heart disease on the left compared to non-severe types of congenital heart disease, and then compare the hospitalization rate among the general population over a period of 5 years. What really stands out is that severe congenital heart disease patients tend to be hospitalized 3.5 times more than the general population. And even the non-severe forms of congenital heart disease patients seem to be hospitalized twice as often as those in the general population. And costs are not only high, but they're also increasing, or at least the resource burden seems to be shifting. Improved diagnosis and advances in medical and surgical therapy have increased survival of congenital heart disease patients, which is really a testament of the success of the work that you do in prolonging the lives of your patients. But at the same time, we're now facing an increasing pool of patients with prevalent congenital heart diseases and especially severe forms of congenital heart diseases. In fact, adults now constitute a significant majority of congenital heart disease patients in the general population, and we expect that in the next decades or so, an increasingly older population of patients will with not only severe congenital heart disease, but also comorbidity that is expected to add to the economic burden associated with this condition. As I said, adults now constitute a significant majority of congenital heart disease patients. If you look at the distribution of patients in the general population with congenital heart disease in 2000, around 55% or so were adults. In 2005, this ticked up quite a bit to around 58% or so. But by 2010, really two-thirds of the population with congenital heart disease patients were adults, with the remaining one-third being children. And to health systems researchers or health economists, this kind of poses an important question because adult congenital heart disease patients seem to be very costly as well. More than half of adult congenital heart disease population is hospitalized over a 5-year period. Approximately 1 in 5 of these individuals are admitted to critical care units during a 5-year period, and severity of their condition seems to be, not surprisingly, a predictor of more intensive outpatient care, emergency department use, length of stay in hospitals, and length of stay in critical care units, which of course carry significant economic implications for healthcare systems. Against this backdrop, that a predominantly adult congenital heart disease population is now falling within the jurisdiction of adult healthcare providers, I think health systems are facing a challenge in the way that this population is really posing a challenge to healthcare systems. Healthcare systems are already underutilized or under a lot of pressure to care for individuals with dementia or other types of chronic conditions. And the types of congenital heart disease patients that are now falling within the general healthcare system is really posing a challenge for healthcare systems around the world. And it's not surprising that, according to the European Society of Cardiology, the provision of care that is provided for adults with congenital heart disease seems to be suboptimal. So I've listed here a number of questions that I think you in the profession need to ask, and those of us looking at it from the outside need to consider within healthcare systems so that better care can be delivered to these individuals from an economic standpoint, from a health systems standpoint. These questions include, for example, which interventions seem to work best for which types of patients, how to transition and coordinate care from childhood into adolescence, into adulthood years, and into older years, how to organize services around a very complex mix of individuals, how to train and effectively allocate the workforce to care for this growing population of patients, and how to deliver services that are not only high quality, but also keeping costs at sustainable levels, which is often the question that many health economists tend to ask. Unfortunately, guidelines seem to be not of much help around these types of questions. And I'm risking being provocative here, but I will take the risk anyway. When I looked at the 2008 guidelines released by the American College of Cardiology and American Heart Association around management of adults with congenital heart disease, I saw a list of recommendations around how to deliver care, how to ensure access to care, how to transition care, and how to deal with psychosocial issues surrounding the adult congenital heart disease patients. Unfortunately, all of these recommendations was rated by evidence at level C, which means that the consensus of experts was the primary source of the recommendation. This, of course, being the lowest rating that can be given to any type of recommendation. Level A is usually given to randomized controlled trials, level B usually given to observational studies, and level C saved for expert opinion. Similarly, expert opinion formed the basis of the European Society of Cardiology's task force on the management of grown-up congenital heart disease around these health systems-related recommendations. And again, this is not really a criticism of the guideline panels by any means. It's simply a reflection of the non-existence of the right type of evidence that can inform important decisions in healthcare systems. So I would argue that against this backdrop, based on these assumptions around how to organize care, how to manage for this population of individuals, I think these assumptions need to be tested by evidence of what actually happens. And I would argue that outcomes research can provide some important answers. By outcomes research, I mean a multidisciplinary field of study. It means social scientists and researchers like yourselves and practitioners like yourselves working together to answer questions around effectiveness and safety of interventions, efficiency of the types of services that we deliver in different centers, different regions, different countries. Are we getting enough value for the money that is spent on certain services or strategies? Is the care that is delivered timely? Are we capturing the right type of patients at the right time and delivering the right type of care at the right time for these individuals? And as healthcare systems, are we actually improving the outcomes that matter to patients? These are the types of questions that outcomes research intends to answer, and it brings together really elements from clinical medicine, epidemiology, statistics, even economics, and health policy to try to answer these questions. And within this kind of a framework of outcomes research, nothing is really off limits. Every element of care is subject to experimentation and study. And that doesn't just include interventions. We talked quite a bit about interventions over the weekend, but also diagnostic strategies, preventive strategies so that individuals are not lost to follow-up as they transition from pediatric centers to more adult types of centers, and delivery of care types of questions. All of these can be addressed within the framework of outcomes research. And I would argue that this is really important because much about comparative clinical effectiveness simply remains unknown in congenital heart diseases. We've recently done a systematic review on the interventions that are done for the coarctation of the aorta, which we consider to be a relatively common type of congenital heart disease as far as these types of conditions are concerned. And we were surprised by the paucity of evidence that directly compared even surgical interventions to balloon dilatation, for example. There are only 2 randomized controlled trials that have been done on this issue comparing these types of interventions, but there's so limited direct comparisons available in the literature to people like myself looking at it from the outside is quite surprising. And I would argue that there's great public value in such rigorous analyses, comparing interventions to each other and comparing different strategies to each other. At the moment, London School of Economics is collaborating with the German Heart Institute in Berlin under Titus Kühne's leadership on a project called CardioProof, which is essentially trying to address these kinds of questions. Technology companies are developing a new technology that can be used as a predictive tool in cardiology, and we're trying to evaluate whether or not adding this new technology to current clinical practice would actually improve outcomes, would actually lead to different types of decisions. And we're trying to get an understanding of whether or not such decisions would actually have cost implications. Because we understand that much about cost effectiveness is also unknown in congenital heart diseases. And this is really unfortunate because fiscal pressures around the world are leading to policies and practices that are designed to restrain expenditures and standardize care by limiting variation. And this is a problem because if we don't know what procedures or services are cost effective, there's no way for us to protect these services and procedures from cost-cutting measures. Policymakers really like to use blunt instruments of cost cutting. They tend to identify the most expensive procedures and then bargain for a lower price for these types of services. As health economists, what we like to think is a need for a more nuanced kind of understanding and trying to figure out what seems to be the cost-effective strategy. Something can cost a lot for the healthcare system, but if we're getting enough out of this kind of spending, then that strategy needs to be saved and protected. And economic evaluation analyses that measure these kinds of value for money considerations are becoming more prominent around the world. And in that sense, I would argue that economic evaluation analysis is a necessary evil, in that we will be able to identify strategies and interventions that provide the most value for money so that limited resources can be spent wisely. And this is not an argument for taking money away from congenital heart diseases and giving it to oncology, for example. It's essentially identifying the strategies that work best for the types of resources that we're spending on them within congenital heart diseases so that we can spend the resources that are available within your centers and within healthcare systems more wisely. And this would allow patient care resources to be directed from interventions that cost a lot for achieving a single outcome to those that cost a bit less for achieving the same outcome, that are more cost effective. And one way of doing this would be looking at practice variations across different centers, different regions, or even different countries. There's significant variability in treatment patterns and associated costs across different practices. If we were to look at the left top part of this figure, and I can see the mouse on my screen, we're looking at the costs associated with doing atrial septal defect repair in this part of the figure. Every box is showing a different hospital. The line in the middle is showing the median cost associated with doing that procedure in that hospital. The top line is showing the 75th percentile of the costs associated with that procedure. The lower line showing the 25th percentile of doing that procedure in that given hospital. What you can see is that there's great variability across these hospitals for doing the same type of intervention for a very similar type of patient. In a given hospital, the cost can change from less than $200,000 to around $400,000, for example. My point here is that just by looking at this variability, which health economists love to do, you can identify certain strategies that seem to achieve the same type of outcomes, but seem to cost less, or they're more efficient. This is not necessarily a cost-cutting strategy, but simply another way of looking at whether or not this variability is justifiable. Is it explained by the significant variability of congenital heart defects, for example? Or is it possible to standardize care or harmonize care a bit more so that we can expect what types of resources are required for different types of procedures? With that said, and I've done this pretty quickly, given this growing complexity of the aging patient population and the cost implications of this complexity, and of course the increasing capabilities of what you're able to do as a profession, I think we need a new research agenda. Social scientists and researchers like yourselves and practitioners like yourselves working together to try to answer these types of questions as much as we can. And I'm happy that this line of thinking is very much shared by prominent professional organizations such as European Society of Cardiology, which is now partnering up with the London School of Economics to offer a new master's program on especially these issues in cardiovascular sciences, health economics, outcomes research, and management. So I would expect to hear, you can expect to hear a lot more about these issues over the next years, I think, as we formally train many of the individuals working in the profession more formally around these types of outcomes research issues. And with that, I'd just like to thank you for your attention.